Join us for this episode of Noon featuring Aaron, a passionate advocate for bridging the gap between EMS and hospital care. Starting in EMS and transitioning into a PA role, Aaron understands the importance of integrating paramedics into the entire health system, not just on the ambulance. As the host of the Practical EMS podcast, Aaron facilitates roundtable discussions with fellow providers on crucial topics like burnout, safety, and impactful stories. Tune in as we explore Aaron's journey and his dedication to improving healthcare collaboration. Let's get started. Awesome. Aaron, thank you so much for joining us on the Noon podcast. How are you doing today?
Good. How are you?
I'm doing great. Thank you so much for joining us. I really appreciate that you reached out and told me that you wanted to be on. Can I go ahead and get an introduction?
Yeah, so my name's Aaron. I've been in emergency medicine for, I guess it's 16 years now, 15, 16 years. I wanted to be a doctor initially when I first started out in college, and my first semester in college was a real eye-opener. It really sucked. I hated it. I hated studying, and I was like, there's no way I can go to school for that long to be a doctor. And someone was like, well, just get your EMT, get your foot in the door with medicine. And I had no idea what that was, and went and got my EMT on a whim and just absolutely fell in love with emergency medicine ever since. And so I progressed to paramedic a couple of years after becoming an EMT. And then while I was in paramedic school, I kind of found out what a PA was and realized that that was kind of my end goal. So while I worked as a paramedic for 7 or 8 years full time for a private ambulance company, I slowly but surely got my prereqs done, got my undergraduate degree, and went to PA school starting in, I think, 2017, and then graduated the end of 2019 and started in the ER at the beginning of 2020, right before COVID hit, actually. And I was like, oh boy, maybe this was a huge mistake. Maybe I don't want to be in medicine anymore, but now I'm kind of stuck. And most of your audience probably remembers, that really sucked for about a year or two. We were, at first, the ER volume plummeted, which was great for me as a new ER PA because I could slowly figure things out and see, less patients than they were used to seeing, and I could figure out how to do this job from start to finish. And so the learning curve was actually a little bit easier to get past. And then as COVID really ramped up, our volumes went through the roof, and it was the absolute opposite. We didn't have rooms for all the patients. We were practicing medicine in a whole different way, not ordering labs and stuff on patients that were just fine to go home. And then on the flip side, seeing all the patients that were dying of COVID, and you would just see, especially the elderly, just so many people super sick with it. And that was a really trying couple of years, especially as a brand new PA trying to figure out the job on top of all of that. And in the last couple of years, now that I've been doing it for 4 years, I've been able to get my head above water and kind of ask myself, what's next? What do I want to do? Now that I've kind of established as an ERPA, and I'm like, I really want to help heal the healers, so to speak. Yes, I'm here to serve patients and heal patients as much as I can, but I really want to speak to the EMTs and paramedics that are struggling, and then the ER staff that's struggling too. So that's kind of how I developed the podcast I have, Practical EMS, is to kind of tell the stories about emergency medicine so that EMTs and paramedics and nurses and docs don't feel so alone with the struggles that they have.
That's great. Great introduction. Talking about going into that, you said that you didn't want to become a doctor. PA school is 2 years short of what a doctor goes through?
Yeah, my program was 27 months, I think. So, yeah, if you look at medical schools, 4 years, it's about half the time. And then even less time than that if you include not doing a residency, although they do have some residencies for PAs. Some people do residencies. There certainly are ER residencies you can do, which I do recommend to new PAs that maybe don't have a strong background in emergency medicine or aren't super ambitious. But for me, I kind of knew what I was getting into. I did a couple rotations in the ER and PA school, and of course, I was a paramedic for quite a while in the same system I work in now as a PA, so I knew what I was getting into. But you definitely have to be able to climb that steep learning curve without a residency. And some people don't make it. Some people realize that maybe they should have actually done a residency beforehand because it's tough. You're trying to do what an ER doctor learned to do over a 3-year residency. Um, so they had a lot more time to kind of figure out the job, in addition to 4 years of medical school. So you're trying to climb a ladder that should be taking longer, I think. But that's kind of the appeal for me to being a PA is, a lot more bang for your buck. You're only in school for 27 months and then they throw you to the wolves and you start working in a specialty or wherever you start working and you kind of figure it out as you go. And that's what I liked because I kind of looked at it as a second career. I was in my late 20s when I looked at going to PA school and early 30s when I finished. And I just didn't want to spend all that time to go to medical school and then a residency and, be practicing by the time I was 40. So it was just kind of um, a nice benefit to PA school is just the shortness, the lack of a gigantic student loan, still a good sized student loan, but at least it's not the size of a mortgage. And you're out there practicing a lot quicker, which is really nice too.
Do you think that having your paramedic license kind of benefited you before going into PA school? And would you suggest that route?
Yeah, I get this question a lot, especially from EMTs and paramedics. And I say that most of medicine does not know the difference between a paramedic and an EMT, which is really unfortunate because we know there's such a huge scope of practice difference. There's such a huge amount of schooling difference. Paramedic school is no joke, right? And you have to do a ton of clinical hours. Your scope of practice is huge. And most of medicine, for some reason, just doesn't realize that. And so if you're an EMT debating PA school, I say just go for it right from EMT. Don't bother getting your paramedic unless you have a strong desire to practice as a paramedic, because it doesn't really help you get in. That being said, going from being a paramedic to being a PA practically helps a ton because the way you have to think as a paramedic and form a list of differentials and get the history from the patient and come up with a plan is all exactly what you need to know being a PA. There's a couple additional challenges and obviously some additional education you need. But I think going to PA from paramedic is a great transition practically. It just doesn't give you a real benefit when you apply, just because whether you're an EMT or paramedic, it kind of is seen in the same light on your application, if that makes sense.
Yeah, and I really like that you pointed it out. I had a partner that came and worked with me when I was on the ambulance that literally only got her EMT license because the first time that she applied for PA school, they told her that she needed some practice in medicine and they told her, get your EMT license. And she only had to be an EMT for 6 months before they accepted her into the next class. And that is absolutely nuts to me, right? Because
Totally.
you and I understand that there's a huge difference between EMT and paramedic. Like, why can't the rest of the world understand that? Most of the world just sees all as ambulance drivers, which is kind of offensive to a lot of us.
Totally. Yeah. Well, one of the docs that was teaching in my program said, all of you guys have no bedside manner, you don't know what you're doing. And I was like pretty offended because I was like, I have seen thousands of patients. I have dealt with critical dying patients by myself. Like the scope of practice and the things that I've done are crazy as a paramedic. Paramedics do so much stuff with such little resources. It's unbelievable. And so practically speaking, it's such a huge benefit to have been a paramedic before because there's nothing that's going to fluster you. I mean, you being a paramedic for 6 months, you've seen so much stuff, especially if you're in a semi-busy system, that there's nothing that's going to really rattle you as a PA. So it's a huge benefit practically for sure, and it's unfortunate that most people don't really know the difference in medicine, and it's frustrating in school. And I tell paramedics that go to PA school, like, you kind of need to put your head down and just get through it, and don't go out of your way to tell all the stories because people are going to be shocked and not be able to relate to it in some ways. I mean, the paramedic culture is, you see a lot of crazy stuff. Like all of us have just crazy stories, right? And they don't want to hear it in PA school. They don't know how to handle it. They don't know how to process the stories you have. Like they want to hear the story from the CNA, that was has a much less dramatic story than you have.
Yeah, no, for sure. Have you seen the TV show? I can't even remember what it's called. It's where the camera crews follow the EMTs out down in Louisiana.
I think I have. I've seen a couple of similar shows at least.
I am very impressed with their professionalism and that they're very good at maintaining that professionalism on the camera at all times because the culture that I know, and maybe it's different from the culture that you know, but we all talk a lot of shit. We talk a lot of shit.
Hmm.
We make fun of people because that is how we release our stress. You know what I mean? And on this show, it's a culture shock to me to watch.
It's probably not accurate, right? Since they're on camera all the time. And I mean, that's the whole emergency medicine culture is we have to laugh about things and make light of things, I think, to get through them. It's part of how we cope with some of the hard stuff we see. And the rest of the world of medicine, I don't think really gets that, but they don't see the stuff that we see. Emergency medicine, and I say emergency medicine now because I talk with the emergency department people and the EMS folks. So I always kind of use this general term emergency medicine, but the stuff that we see is so far so different than the rest of the world sees and the rest of what medicine sees that we have different coping strategies, and I think we require different coping strategies than everyone else. And part of that, I think, is making light of things and maybe joking about things that nobody else really would joke about.
Yeah, no, I agree. And it is very true. We have some really fucked up ideas of what's funny and what's not funny.
Right.
So, you have kept your paramedic license. Why do you keep it?
Just in case I get fired. It's
Is
kind of a
that a
joke, but
concern?
no, I think I kept it because I did work part time all the way through PA school and then even a little bit when I was a brand new PA, just to kind of keep busy and stay on the ambulance and stay in touch with the crews. And then it ended up just getting too difficult to stay part time with technology changes. I mean, like anything, there's updates to things, and I was working so infrequently. I felt like I couldn't keep up with it. In addition to my main job as a PA, truthfully, I keep it because it's easy to keep. I need, I think, 100 CME credits every 2 years as a PA, and I think paramedic requirements is like 40 or 50, and I can use them for both. So it's very easy to just keep it and renew it. And I just like being a paramedic. I mean, that's what I did for so long that I still identify with it a lot, and I still really like to relate to the crews. And yeah, I don't know that it's a job I would ever go back to, um, just because my scope of practice now is a little bit different. I'm not used to being on the ambulance, um, but I think the short answer is it's easy to keep, and so I do.
Yeah, no, and I appreciate the honesty. And you talked about saying that you don't know that if you would ever go back as a paramedic. And it sounds like mostly it's a technology based issue, right? Not being able to keep up with the changes that are happening in medicine itself, not because you were burnt out. Is that correct?
Yeah, it was more a matter of, the way they get calls is different on these like cell phone type devices. The way they get dispatched is different. How you call into the hospital with the patient information is changing. Um, and a lot of that stuff gets updated pretty consistently. And so if you're not doing it very often, I felt like I was just behind the times on all of that. Um, but yeah, not because I was burned out. I actually want to schedule some third rides with our private ambulance here, just because I like to interact with the crews and see what they're still dealing with on a day-to-day basis. Because I think it means a lot to them when the providers that they give handoff reports to every day kind of can relate to what they're dealing with and the stresses that they have. So that's still on my list of things to do is try to third ride with them.
I think that's fantastic. And I think that you should do it. I think that, we talked a little bit off air before the episode started, and you do have a very strong connection with the crews because you had that paramedic license, which is fantastic. And then being able to, enforce good, positive mindsets with these crews helps them want to stay in the job longer or even promote up to a higher position. Do you mind if I ask what the pay difference from a paramedic to a PA was?
I would say in rough numbers, even when I worked a lot of overtime, it's still about probably double what I was making as a paramedic and for a lot less hours. I probably work half the hours that I worked as a paramedic and make double the income, if that makes sense.
Yes.
So it's a substantial difference. Um, but I also tell like because a lot of paramedics have considered PA school and it's looked at as a second career for a lot of people, and it really is for a lot of people. It is a second career, but it's something that you have to go all in on. It's so competitive to get into PA school and so hard to get through a program that it really has to be looked at as like your number one goal. It can't be looked at as something like, oh, when I'm burned out being a paramedic and when I'm older and tired of being a paramedic, I'll go to PA school. It's really got to be something that requires singular focus. Like you've got to dedicate volunteer hours and get a good GPA and get all the ridiculous classes done that they want as prereqs. And it does require a lot of dedication to get to that level. And so I understand why there's the pay difference, but I wish that there was a better progression for paramedics, but they have these different degrees and everything, and none of them really equate to more pay, which is unfortunate. So it's like, why get a bachelor's degree in emergency medicine if you're not going to get paid more as a paramedic? It's you're making a school richer for no good reason. So I tell people if you're motivated and you can make that your singular focus. PA is a great progression from being a paramedic because you do a lot of the same things. You just have a little bit bigger scope and a little bit more responsibility, but the pay is a good motivator for sure.
Yeah, no, definitely. And I don't know any PA programs that allow you to work at the same time that you're in school. Like I'm pretty sure you have to sign a contract or something saying that you're not going to work because you want this to be a successful venture, and it's expensive.
Yeah, it's more full time than my paramedic school was. It's basically 9 to 5, 5 days a week through the majority of the program. It's not something that you definitely can't work full time. And I probably would go several months without working. And then sometimes, like over a long holiday break, I would work a whole bunch. But yeah, the majority of PA programs, you really can't. It's basically medical school condensed down into as short as they can make it, in 24 months to I think up to 3 years. Some of the programs will go, but they try to condense down medical school into that period of time. So it's very full time kind of education.
So is this kind of your end goal is ERPA, or are you looking at other ventures as well?
Yeah, this is definitely my end goal as far as medical stuff goes. A lot of people do ask that question of PAs is like, are you going to go to medical school? There's really no like great progression from PA to MD. You really kind of start all over again. I think there's some programs that make medical school a little bit shorter, but at the end of the day, you're really starting completely over again. And, now that I've been in the ER for 4 years, that's the equivalent really of a longer ER residency. So, it would be rough to go all the way back through with a regular medical student that hasn't really practiced. So ERPA, I think, is where I'm going to stay. I love emergency medicine still. I don't think I could do any other specialty. The patient volume, the patient acuity, the fact that there's always something to do and that the days go by really fast is what I love about it. I love not looking at the clock, and I love being able to take care of critical patients. And depending on the environment you work in as an emergency medicine PA, sometimes you aren't going to see the critical patients. The system I work in is phenomenal because it's a team mentality, meaning we see all the patients with the physicians, and it's kind of a very teamwork oriented environment, which is what I think is the best because we're all taking care of all the patients. It's not like the PAs are seeing the low acuity coughs and colds and the docs are seeing the critical patients. We see them all as a team, and that makes it the most efficient. And I think takes care of the patients a lot better too, because you're getting two sets of eyes on all the lab works and imaging, and two sets of people, consulting the specialists. And so I think it's a more efficient way to move patients through the ER. But depending on where you work, it's not the same. You might just be seeing the low acuity patients every day. A lot of different systems do it differently. And so I also tell people to keep that in mind too when you go to PA school and you want to work in the emergency department is you may not have a system that really uses you to your full scope. And I feel like our system uses us to the full scope, which makes it a lot more satisfying. So
Yeah, no, that's fantastic. And does your facility recognize NPs or nurse practitioners at the same level as the PAs?
Yeah, we kind of all fall under the umbrella of advanced practice providers. So we hire NPs and PAs basically at the same rate. And I'm obviously biased towards PA school, so I think PA school is a little bit more robust than nurse practitioner school. If I had to do it all over again, I almost wonder if I would have gone the nursing route, just because NP you can get online, you can work as a nurse while you're doing it. So there's some benefits there, but PA school is a little bit more the medical model that doctors are trained in, and kind of the thinking that paramedics are trained in as well. So I'm partial towards the education of PA. But that being said, after you've been in the ER for 1 or 2 years, the NP and PAs are, the equivalent provider. I just think the NPs probably struggle a little bit more, especially if they weren't in the ER before NP school. If they were in a different specialty or something that was lower acuity, they struggle a little bit. But that being said, a brand new PA does too, especially if they
Yeah.
were, not heavily patient experience before PA school. So there's definitely multiple facets to that. But 2 years into practice, you're basically the equivalent provider.
That's great. I mean, it's really cool that they utilize both the PAs and the MPs because there are a lot of states that don't recognize that. There are a lot of facilities that don't recognize that. So it's really
That's
cool.
true. Yeah.
So, in all of your experience with the ambulance and now in the ER, which one would you say has been harder, patient wise, like treatment wise?
Honestly, I think I had more difficulty as a paramedic, stress wise. The stress in the ER is a little bit different, I think. When I was a paramedic, like there was nothing more stressful than being 45 minutes out from the hospital. You've got to RSI a patient all by yourself. You've got to figure out the medication doses all by yourself. You've got an EMT there that may or may not be able to get your IV for you. And you've got to intubate a critical patient. And man, with no resources out there in the middle of nowhere, I mean, that is a stress level like no other. And I have not been able to match that stress level in the ER as a PA. And honestly, I'm grateful for that. It's kind of nice not to have to deal with that stress level anymore. In the ER, we just have so many resources, especially where I worked in a level 1 trauma center. There's always a physician around. If we're intubating a patient, the physician's in the room 9 times out of 10 or more. And not that I don't intubate, but there's usually another provider there. So I'm almost redundant if we're intubating a patient. I'll do it to get the skill and keep my ability to intubate patients. But honestly, if the department's falling apart and there's a bunch of other critical patients, I'm just going to leave the room to go take care of the other patients, because there's no reason for 2 providers to be in the room. So part of it, you have to take efficiency into account and, go see the other patients that may or may not have been seen by a provider that may or may not be critical. But my stress level in the ER is much more volume based. We're multitasking. And I say there's really no such thing as multitasking. You're doing one task at a time, but there's always something to be done in the ER. We might have 16 active patients, up to 20 active patients sometimes, and they're all in various states of workup. Some of them need to be seen right away, need orders put in. There's an ambulance arriving. Somebody's pressure's dropping and you need to address it. Somebody needs a central line. This one needs to be admitted. That one's ready to be discharged. And so you have this, long list of dozens of things you could be doing at any given time, and you need to tackle them in a particular priority. And so that's the stress in the ER, is just having this long list of tasks, and you need to prioritize them and deal with the critical patients, deal with the discharges, deal with the admissions. And that's kind of the stress level in the ER. But it's better because most of the patients aren't dying. You don't have to go and intubate somebody every 5 minutes. That's a much more rare occurrence. It's much more dealing with patient dispositions. And so that stress level is a little bit easier to deal with, than one super sick critical patient an hour out from the hospital.
It sounds like you delegate yourself accordingly because that was going to be my next question. Do you ever feel like there's too many chefs in the kitchen?
Yeah, and that's a good question. I think when you're a brand new ERPA, the docs have to help you out a lot and help you prioritize those tasks. And as you develop the experience, you end up deciding what warrants your attention right away. And a good physician PA team does delegate these things and you don't do a bunch of redundant work. So if a new patient arrives by ambulance, we both don't need to go in the room unless it's that slow. One of us can go and hear the EMS report, put in orders on the patient, do our own exam, get our own history, and get that patient started, while the other one goes and discharges another patient. So part of being in the ER and the stuff I really focus on is efficiency. So if I see the doc's going to go discharge somebody, I'm going to go do something else that needs to be done. I'm going to consult the specialist, or I'm going to call the surgeon for the acute appendicitis, or I'm going to admit the patient that needs to be admitted. So we try not to do a lot of double work. Um, it's hard with certain physicians. Everyone practices a little bit differently. Every physician's a little bit different in how they work with PAs. Some people do like to micromanage us a little bit. Some people want to give us full autonomy. And so as a PA, you do kind of have to adapt to the physicians you're working with. And that's something that's not talked about a lot, but you do change your practice depending on who you're working with. And at the end of the day, the physician, I'm gonna do what the physician wants, right? They went to medical school, they did a longer residency, and if they want to work up a patient with a whole bunch more lab work and imaging than I think is necessary, that's what we're going to do. It just makes things move a lot less efficient. Sometimes they want to go in and see every patient together. So we're both standing in the room, getting the history and doing a physical exam. And it's not efficient to do it that way. And that just makes the whole department move slower. And so that's how I try not to do things. I try to not do redundant work, because I think it slows everything down. It's not the most efficient way to take care of the patients. And the patient doesn't want to tell their story 1,000 times either. Some of them do, but a lot of them don't. So you do adapt to the physicians you work with, and that's one of the skills you have to develop as a advanced practice provider, is how you work with certain physicians. And some people practice very similarly to how you practice, and if they practice similarly to how you practice, that makes it easier. But
And I feel like that can be carried across over into the EMS world too, right? Like the way that I am working and treating might be dependent on the partner that I have in the seat next to me. If I have somebody who's burnt out and I know is like only going to put on a pulse ox on this patient, I'm going to have to be doing a little bit more to cover for what they're lacking in. Do you ever feel like you've had to, because you talk about how there's a lot of redundancy and sometimes maybe the physicians are doing more than they might need, but have you ever had to advocate for a patient who maybe needed more than what the physician was doing?
great question. Yeah, absolutely. That definitely happens too, where you're like, you're worried about a particular differential that's not really on the physician's radar. And you're like, hey, I think we should order this test. And a good physician will say, yeah, if you're worried about it, order it. Or, depending on how well you work with that physician, you just order the test. And honestly, that's the answer most of the time is, especially if we're super busy, I just order the test that I'm worried about. I don't clear it with the physician. Um, especially if it's like, a lot of these are like PEs. If you're concerned for a pulmonary embolism, should we order a dimer? Should we order the CT scan? If you're working fast and you're working efficiently and you're not talking in depth about every patient, I just order the test to rule it in or out. Um, if we're slow enough that we're talking in depth about every single patient that's coming through the door, sometimes I will bounce it off. I'm like, hey, are you concerned about this at all? If I'm personally not that concerned. But if it's something I'm really worried about, I just order the test. And a good physician will not even bat an eye at that.
No, that's fantastic. And it's good that you have that great of a rapport with your healthcare providers. It's fantastic. I think sometimes that's hard to find, especially in systems that, well, and especially today, right, where we're short staffed and we're constantly changing providers, and that's in all levels between techs, EMTs, paramedics, nurses, doctors, PAs, MPs, all of them, it's hard to
Mm-hmm.
adjust to that. So it's good. It sounds like you have a good rapport with the people that you work with and with the people that not only are in the ER, but also in the field. Do you think that should migrate to be more of a teamwork effort from both outside of the hospital and inside of the hospital?
Yeah, I think it's hard to see the struggles that the EMS crews are having, from inside the ER, and they don't see a lot of the struggles we have too, with their brief glimpses into the ER when they come in. Because a lot of the things I saw from the outside are really not the case, from the provider side in the ER, if that makes sense.
Yeah.
When you come in as the EMS crew, sometimes you don't realize how busy the department is. You drop off the patient, give handoff report, and leave, and don't realize that, we have a waiting room of 20 people we're trying to move through. But I try to include them as much as I can. And I think part of being a team with the EMS crews is listening to their full report. That was always something that drove me crazy as a paramedic, was the physician interrupting halfway through and cutting me off or talking to the patient while I'm giving report. It's like, if you had listened to my whole report, I would have answered all these questions that you're interrupting me with. So I try to keep that in mind and spread that to other providers as well, as like, listen to the crew's full report. Like, they're probably going to give you the information you want. You just need to wait for it instead of interrupting with questions. And some providers are better at that than others, and I try to be good at that. One of the things I try to do in the ER is walk slowly from room to room. You get a lot of people that are in this huge hurry. They're sprinting everywhere, and most of our patients aren't dying. You don't need to be sprinting from room to room to save 5 seconds. So I try to be a little bit mindful. And well, while I'm walking to a room, I take a couple deep breaths, prepare myself to listen fully to the EMS report, give the patients a chance to talk, do a good physical exam, and try to slow things down a little bit, because the rest of the ER staff responds to that. If you're running to the room and you're super anxious and you're interrupting the crew and you're starting your physical exam while they're still giving a report, that makes everybody anxious, and it makes the crew feel disrespected, and they're not going to want to give you a report next time. And everybody walks away from the interaction feeling worse than when we started. So I try to keep that in mind when I'm working in the ER, is that, we need to slow down sometimes and actually take the time to hear a full report. Because if you take that time up front, you're going to miss a lot less things later. And when you go to discharge a patient, the patient's like, well, what about my chest pain? And you completely miss the fact that they were having chest pain. It's worth doing that work up front and actually slowing down and listening to everybody and understanding everybody.
I agree 100%. So now that you've seen it from both sides and you're asking your fellow providers, hey, slow it down and listen, is there anything that you would ask from an EMT to bring in, like from the opposite side?
Yeah, totally. When I got trained to do handoff reports as an EMT and as a paramedic, the stuff that they told me to put in the reports is really not what the providers necessarily need to hear, or at least it's not emphasized correctly. What I try to tell the crews is, like, I need you to lead with the chief complaint. Because if you're telling me all their relevant history and their cardiac history and all that, I can't put it in the proper context and really hear what you're saying unless you lead with the chief complaint. In the emergency department, we really operate based on that a lot more than you do on the ambulance. On the ambulance, you get the dispatch information, right, which may or may not be accurate at all. And then you talk to the patient, you actually get their story and determine what the real chief complaint is. When we register a patient, they're pretty good at accurately describing what the chief complaint is. And so if I can use that as the context, I can hear everything you're saying and actually digest it a little bit better than if you tell me the chief complaint 5 minutes into the report. So if you lead with, this patient called for chest pain, then I know what all the relevant details you're about to provide are. Versus if you're leading with vital signs and all this other information, I can't process it in my brain if I don't have the proper context. So I always tell them to lead with the chief complaint. Some other tips too are to be somewhat brief. I don't want to stand there and listen to a report for 10 minutes, just because we don't have that kind of time typically. So brief is better, because I'm actually going to hear everything you're saying. Be concise. Try not to pass on any of your bias onto the providers too. We all have our own biases, right, that we're working with. And if a patient looks anxious and, you say this is an anxiety attack, like, I don't need your help looking at the patient to decide it's an anxiety attack. I want you to give me more objective information to make sure I don't need to rule out a PE. Because occasionally patients come in looking like they're having a panic attack and they have a PE. And so I don't need you to tell me, like, hey, I think this is an anxiety attack. Like, I'm going to probably be thinking that anyway, but I'm also going to be thinking, how do I prove this is not a PE? Sometimes that's a great physical exam. Sometimes that's a good history on the patient. And sometimes we need to get a CT scan to really rule it out. But we have to start with a much more broad differential diagnosis, I think, than sometimes the paramedics will start with on the ambulance. And it's not that I don't want to hear their differentials. I think they're valuable. but I'm going to still have to broaden it out a little bit. And the more they pass on kind of their bias and how they're writing off the patient, I tend to mentally broaden the differential even further because I know subconsciously I'm getting a little bit biased already by listening to the report. So I really try to tell them to be objective in the report because you're not doing the patient any favors by passing on your bias that oh they're just drunk or oh they're just having an anxiety attack. Like we all kind of think that anyway, right? We're all in emergency medicine, like we've all seen it a lot, but I need to think a little more broadly just to make sure we're doing the right thing for the patient.
Yeah, I think that you're pointing out a really, really big problem that a lot of paramedics have, right? You're like you're saying the bias. I mean, I can tell you, I couldn't give you numbers, but how many of our ETOH or alcoholic friends have died in the waiting room because they weren't fully assessed?
Right.
You know what I mean? How many have we seen that we've just walked up to triage on the stretcher and put them in triage on the on the floor or on the chair wherever they're going, and they end up getting missed for several hours because we told the nurse, they're ETOH and don't worry about it.
Right.
So I think that brings up a really good point.
Yeah, I think just it's hard to be objective, especially when you're burned out. You've run 1,000 calls today, but it really comes down to advocating for the patient and just making sure that you give as objective a report as possible because we're all already dealing with bias. We're all trying to fight that as much as we can already. So when you bring that bias into your report, it just makes things even worse and just much more likely to get missed. So
Yeah, I agree. Speaking of burnout, was there any point in your career where you were feeling burnt out?
yeah, I've felt burned out a few times in my career. Sometimes it's kind of what I call acute burnout, like just having a rough couple of shifts. Sometimes you have that week where you run multiple cardiac arrests or a pediatric cardiac arrest, and you do this several days in a row, and you're getting off late, and you're behind on reports, and maybe you messed up a couple skills that you should have been able to perform. And sometimes it just takes a couple shifts in a row like that to really burn you out. But the acute burnout, I think, is pretty easy to recover from. A couple of days off, doing things outside, exercising, hanging out with your family, you can fix that acute burnout. But the chronic burnout, I think, is the bigger issue, and I think a lot of crews suffer from this, and that's what I suffer from, periodically as well. It's when you're not doing the things you need to do for yourself, and you're not taking care of your own mental health, you're not taking care of your own physical health, you're kind of letting things slide slowly over time. You have a rough shift here, a rough shift there. You're mad about the system you're working in because you can't control it. And, slowly over time, you just develop this burnout. You see patients as just as patients. You don't see them as humans anymore. You start that dehumanization thing. And that's a lot harder to combat. I had that, I think, more when I worked a 48-hour shift and I was in school full time and I was picking up overtime. And there's no doubt that, especially in EMS, sometimes you've got to make work a high priority. You need to make money. You need to work that overtime shift to provide for your family. And I get that. Like there's periods of time where you've just got to grind. But I think the longer you do that and the longer you put your family on the back burner, it just comes back to bite you eventually. And the thing I've realized, especially in the last couple of years, is you've got to take care of yourself before you take care of patients. Even if that requires you getting up early before your shift, if you need to do some meditation, if you need to be making sure you're eating proper nutrition and exercising and doing whatever it is for you to help you cope with the crazy shit that we see every day, you've got to do it every day consistently in order to avoid, I think, that chronic burnout. And the more you let that stuff slide, the worse it is for your physical and mental health.
I agree. Because why are most people in this type of career? We're in this career because we don't want to do the 9 to 5. We don't want to do that. But we're not taking care of ourselves to prevent from getting into a position like that. So get up, take care of yourselves, guys. Like, I don't know how else to put it. I will admit first, I was one of those grumpy, pissy ass paramedics because I worked so much overtime all the time and I didn't take care of myself. And I've gotten to a point where I can settle down a little bit and figure out, well, there are things that I like to do, and that helps. That
Hmm.
helps me get through my next shift or my next couple of shifts or whatever I need to do. So it's a huge, huge, huge factor in what we do and how we do it.
Yeah, emergency medicine is just too hard of a job, and we see too much crazy stuff to be non-intentional about our mental and physical health. I mean, you just have to be consistent with it because there's not a lot of other careers that are like that, but we are asked to see the worst of humanity and the worst things that people do to each other, and we see it on a fairly regular basis. And if you don't cope with that properly, I mean, we all have colleagues that have abused alcohol or whatever substance is their vice. They take it to the extreme and they eventually die from it. I mean, this job will kill you if you are not intentional about working on yourself before you work on patients. And that's kind of one of these. I have these emergent standards that I'm kind of writing down, that I call them emergent because if you don't develop standards for yourself and you're not consistent about it, eventually they become an emergency, right? Like if you don't drink enough water every day, eventually you're going to be super dehydrated and now it's an emergency. So these standards are emergent things you need to be working on every single day. And your mental health is one of those big things. Your physical health is one of those big things that eventually it's going to be an emergency if you don't address it today. And so I try to have these standards for myself that I work on every single day, to avoid it becoming an emergency down the road. If you don't work on your mental health every single day by talking with your family or meditating or doing whatever you need to do to get yourself in the right headspace, it might not be tomorrow, might be not next week, but in a couple months, you're going to have a mental health crisis and it will be an emergency and you'll have to address it at that point. So I think it's worth consistently addressing this stuff every day before you get to a crisis point.
Right. And that's a great suggestion, right? Having those emergent standards. That's a neat way of thinking about it. And if you don't know what it is that will help you, don't be afraid to try things. Not everybody wants to talk to somebody about how they feel. But if you've never done it before, maybe it will make you feel better. Or, meditating, like you were saying, take that couple of seconds before you need to go to do the next thing and just take a couple of deep breaths to get you through. Try the yoga, try working out, try doing whatever you want to do to see if that helps you get through, again, your next shift or your next couple of shifts or whatever you need to do to make it better for you.
Yeah, absolutely.
So do you feel comfortable, Aaron, talking about maybe one of your worst calls?
Yeah, I don't know that there's one specific call that I would say is my worst, but I've had a lot of those calls that still circulate through my mind from time to time. And most of them are, I ran a call, you know, I think especially when you work in a city and you live in that city, just driving around town, you can look at different intersections and be like, oh, I remember that call at that intersection. I remember a call at that intersection. I remember a call in that neighborhood. And those are the ones that still kind of cycle through my mind periodically. But some of the worst ones that I can think of are pediatric cardiac arrest, that we couldn't get back. So I was working a 48-hour shift and we get called at like 2 a.m. It was one of these shifts where we just got our butts kicked the whole 48-hour shift. And you're on this 48-hour shift, you're supposed to be able to sleep periodically. You're not supposed to be awake for 48 hours, but we had been awake for the majority of the shift. And we get called at like 2 a.m. the second night. We're super tired, super burned out. And we look at our pager and it's for a cardiac arrest. And we're both like, oh, fuck. So we hurry down to the ambulance and our ETA is like 30 minutes. This call's out in the middle of nowhere. And it's a little kid. It's like a 4 or 5 year old kid. And so we haul ass, right? We're not following policy. We're just driving as fast as we can to get there because minutes actually matter on this call. It's not, some abdominal pain that we're going to. And we get there and the BLS fire department had done a great job so far. They're doing chest compressions. No drugs had been given. So, I'm pulling up epinephrine and intubating the kid and doing everything we can. No shockable rhythm or anything. And we can't get return of circulation on this kid. And we ended up still flying him out because I just didn't have the heart to pronounce him. And, they didn't make it, of course. But calls like that just really weigh on you. I mean, that was, probably 5 or 6 years ago, but I still think about it because it's like, life's really not fair. These kids, are innocent. And I think that those are the hard ones when it's an innocent kid that's involved and there's no good reason for it. And it's like, you really got to be intentional about recovering from something like that. That's not something you forget in a day or in a week. And if you dwell on that call and run it over and over again in your mind, that's not healthy either. I think about the drunk driving car accidents I've run where the drunk driver's totally fine and the passenger got ejected and their brains are all over the street. And, I think about the domestic abuse calls where somebody's, really a really traumatized patient and you've got to deal with this chaotic situation. And I don't think there's any one call that's like the worst call I've ever run, but it's just a lot of those that kind of stack up over time, I think, that make the job difficult.
So, what do you do to make yourself feel better?
That's a good question. I think you got to have somebody to talk to, whether it's your spouse or your family or a coworker or a mentor. I think just talking about this stuff really helps you process it. And if you don't have somebody to talk to, or if you aren't comfortable talking to somebody, sometimes just writing it down can be really helpful because it forces you to focus in on what's bothering you about it. So I tell people to do this sometimes is just take out a piece of paper and write out the entire situation you dealt with, how you felt about it, and just read it over a couple of times. Try to process it, try to process how you felt, try to process what maybe lesson you learned from that call, and then just tear it up and throw it away and stop thinking about it because dwelling on these things eventually will kind of tear you down. I also tell people that you've got to develop the right coping strategies. You can't turn to alcohol. Drinking will make you feel great for a couple of hours, but the sleep deprivation and the next day will make it far, far worse. And so you've got to be really careful with substances like that because they can be so tempting because it's going to make you feel better that night, but the long-term repercussions of over drinking to cope with the stress that we have is only going to harm you long term. And we all have coworkers, that we can point out that have dealt with it in the wrong way. So you've got to develop intentional, good coping strategies. And I think that just comes back to taking your care of yourself first thing in the morning before you go to work. You've got to do whatever it is for you that makes you feel good, makes you feel cared for, and makes you feel healthy. And for me, that's daily exercise, that's hydration, that's watching my nutrition, and writing really helps too. You've just got to be intentional about that stuff because otherwise it's just gonna eat at you, and you're gonna find the easiest way to cope with it. And I've been guilty of, these are not things I'm perfect at by any means. I've been guilty of coping the wrong way many times. Like I would binge eat after a bad shift, consistently, like every day for a week. I would be like, well, guess I'm going to go home and eat a pizza tonight. And that's how I'm going to cope with this stressful shift. And eventually, it makes you not healthy. So whatever your vice is, you've got to be able to overcome it and not use it as a bad coping strategy. And everyone's vices are different, but you've got to overcome them and realize what they'll do to you long term if you don't overcome them.
Right. And don't be afraid to call out your coworkers. You know what I mean? Don't be a dick about it, but just say, "Hey, something's different, something's off. What's going on? Do you want to talk about it? Is there something I can do to make you feel better or to help?" Right? We have to get to a point where we're checking on our coworkers and making sure that they're okay. We can't be responsible for them, but we can at least try to get them into a better position.
Absolutely. And I think it goes a long way just asking that question, like, hey, are you okay? If you ask it with that attitude that you actually want to know the answer and in an unrushed situation where they actually can give an accurate answer, I think that goes a long way because we all say, hey, how you doing? That kind of thing. But if you can actually look them in the eyes and say, hey, how are you doing? And give them the chance to answer, sometimes you'll get some good responses from people and it'll actually help them be open and honest with you so you can actually do something to help.
Yeah. Yep. So what's uh in all of your years in the field and in the hospital, what's one of the craziest things that you've ever seen?
That's a good one. I think the craziest things I've seen too, I feel like there's just a bunch that kind of come to mind. For me, the craziest are like kind of the coolest thing I've done. like I can think of just a handful of situations where I actually feel like I saved someone's life. I think the people that look at EMS from the outside are like, you guys save lives every single day. And that's not really true, right? I mean, every now and then you get that call where you're like, I did something that actually made a difference. So when I think of the craziest call, I think of the ones where I feel like I actually did something that made a huge difference. And that's part of what attracts me to emergency medicine is you get that opportunity sometimes to do something that makes a huge difference in a short amount of time. And I can remember this one call. We were headed back from the hospital to our post and we were monitoring this fire channel because the fire department was out on an electrical hazard on the side of the road. Well, this woman had pulled up with her dad in the passenger seat. She just pulled up next to their fire truck because she saw that they were there, and she said, "Hey, my dad needs help." And so we just happened to be monitoring that channel, and we were about 30 seconds away. And so they called for us, lights and sirens. We pulled up probably seconds after they pulled this guy out of the car, and he had just gone into cardiac arrest. He had a pulse, right before they pulled him out. So we load him on the stretcher, throw him in the back of the rig real fast, and newer paramedic Aaron's like, "Oh, I need to intubate this guy," and I was like, "Hold on, let's put the pads on him first here and see what his heart's doing." And so I refocused on the first priority. We get the pads on him and he's in VTAC, and I was like, "Oh, I know what to do for that." And so we light this guy up and start chest compressions, and he pushes us off, and he's back in a normal rhythm. And we put the 12 lead on him. He's having a giant STEMI. But we were like, we actually shocked this guy back to life. And I was like, that is one of the coolest things you can do in this job is where you can be in the right place at the right time quickly enough to actually affect a change. And so that's one call I think back. And, there was a handful of situations like that, over my career where I was like, I actually pushed the button that made a difference on this patient. And, it feels good to actually do something like that occasionally because we don't get those opportunities that often.
No.
It's sometimes it can be extraordinarily rare that we have that kind of opportunity. And so when I think of craziest call, I think of something like that where we actually affected a change in a short amount of time.
Yeah, no, that's a great story. And I think that it's really hard to express to people how violent defibrillation is, right?
Yeah.
That's super aggressive. And I didn't realize, I've been in EMS for a long time. I've been pushing that button a long time, but I just recently started teaching the AHA card, so BLS. And when you're telling them, we're going to defibrillate this patient, I think they just think it's going to be a shock and it's over. But no, you need to explain to them this patient is going to flop off of the floor probably for a second
Yeah.
before they come back down. It's a very violent process.
Yeah. And if they don't flop very hard, that means they probably aren't coming back.
Right, exactly. It's oh man, that's a good one though. You're right. We rarely get the opportunity to make a difference. And then even more rarely do we get to see that difference actually become something. So getting that patient to be awake to the point where he's pushing you off is fantastic. I've been kind of following. I follow the pre-hospitalist. I had her on the show a few episodes ago, but she posted something recently about how they're talking about making guidelines or protocols for patients who are in cardiac arrest, but when you do chest compressions, they actually come back to life enough to push you off and to wake up and to tell you to stop. And then when you stop, they go back into cardiac arrest. So the only way these people are perfusing is when you were actively pumping their chest, and they're talking about protocols on what to do for those patients. Do you think that sedation for these kinds of patients is a good idea?
That's a great question. I mean, this is such a weird scenario. I don't think I've actually ever seen this happen, but I have a few colleagues actually recently that were telling me a couple stories they've had where you're perfusing their brain so well they do push you off. And that's a conundrum because you can't really stop the compressions, but you also can't have them pushing you off. So I mean, I don't know what you would do other than, RSI them or something.
Yeah.
Because they're probably going to have a gag reflex and everything. So I think you probably would have to sedate them. Thinking back, I don't know that I've actually ever dealt with that. Although I did have a patient when I was a brand new paramedic. He was running on a treadmill at a gym, young, healthy 21-year-old guy. And we get there for what was a seizure. And we get there and he's in full blown cardiac arrest, no compressions being done. So we started compressions. We would give epinephrine, and periodically he would still not have a pulse, but he would start to have seizure activity. And to the point where his jaw was trismus, we couldn't get an airway in him. And so I was like, do I give benzodiazepines to treat the seizure? And we didn't have RSI at the time. And it would have the side effect, obviously, of stopping the seizure, but also allowing me to intubate him too. But it was a confusing situation. So we ended up giving benzodiazepines for the seizure, and that relaxed him enough that I could intubate him, but he still remained in cardiac arrest. We did get pulses back at one point, but that's the only scenario I can think of that's similar where, in cardiac arrest, you really shouldn't be having seizure-like activity. But patients do not fit the textbook, that's for sure.
Yeah, unless the seizure activity is secondary to the cardiac arrest, such as a VTAC
Right.
or VFib, right? Because sometimes we see that. But
Yeah.
I think if they're to the point where they're waking up while doing chest compressions, we should probably be sedating them. I think that's kind of messed up, right? Because they are waking up enough to push you off. So, and if that's the only thing that's keeping them alive, then we should probably continue to do that until we can either get an internal pacemaker or whatever is going on to reverse the etiologies that's causing this cardiac arrest.
Yeah, yeah, it's an interesting situation for sure. I didn't even really, yeah, I wasn't even aware that that happened very frequently until I was talking to some colleagues, and they all had a few examples of that where chest compressions are actually perfusing them enough that they need them because you stop and they stop, but they're pushing you off when you're doing chest compressions. That's a crazy scenario for sure.
It is crazy. And I think through our research and through AHA's research and where we are now, I think we will probably start seeing it more and more frequently if we're not getting ROSC immediately, but only ROSC because of the perfusion that we are providing them.
Mm-hmm.
That one's a tough one.
Yeah, definitely.
Yeah, Aaron, I want to give you the opportunity to talk about anything that you feel that we didn't talk about, or if you want to shout out any resources or anything that you have in mind, go ahead.
Yeah, so my podcast is Practical EMS. You can find it on podcast platforms. If you go on YouTube under Practical EMS, you can find my clip show where I kind of put the highlight reels from the different episodes. I try to release something every week. Usually I get an EMT, a paramedic, a nurse, a doc together, and we just tell emergency medicine stories with the goal of kind of helping make sure that nobody feels alone in the crazy stuff that we're seeing. And we do that every week. So yeah, go check out the show. I don't make any money from it, so it really helps if you can subscribe. And then I'm under Practical EMS on all social media platforms as well. You can go to practicalems.com is my website. I do have an EKG course on there if you want to financially support the show and increase your ability to interpret 12 leads. Yeah.
That's fantastic. I'm going to go check out that EKG thing because I've had a couple people in the last couple weeks ask me if I have any really good EKG resources. So I'll have to check that out.
Yeah, I'm trying to get it CME accredited because that's really the only reason anybody does any further education in medicine. So I'm trying to get it CME accredited, which is a little bit of a process, but I'm hoping to have that soon. Yeah, and paramedics, that's one thing in PA school too, is paramedics are really good at interpreting 12 leads and the rest of medicine not so much. So that's why I created that resource, honestly, is for a lot of even advanced practice providers because they just don't get that in school very much. So
yeah, which is unfortunate. And even paramedics don't really get, I feel like a lot of paramedics go out of their way to learn more about EKGs because when I went through paramedic school, my EKG course was 2 weeks and it was kind of a joke.
yeah, I'm sure it does vary kind of from system to system.
Yeah, no, it does. Awesome. Well, thank you, Aaron, so much for coming out today on the 911 Nonsense podcast. It's been an amazing conversation. I've enjoyed learning about you, who you are, what you do, and why you do it.
Well, thanks for your time, Sam. I really like your show and I love having these conversations. So I want to do more of it and had a great time.
Yeah, I look forward to hearing more of yours, and I hope you have a good day, bud.
Yeah, you too.
Thank you for listening. Before we wrap up, we have a few important announcements to share with you. Firstly, we're excited to announce the launch of our brand new 911 Nonsense Facebook group page. It's a community where everyone can go to connect, share ideas, discuss topics from the show, and get all of the most recent updates about the podcast. We'd love to have you join us and be part of the conversation. Next, we want to ask you to rate and review our podcast on your preferred platform. Your feedback means the world to us and helps us reach a wider audience. By rating and reviewing the show, you'll be supporting us in a big way and helping others discover 911 Nonsense. If you enjoy what we do and would like to support the podcast even further, we have a few options available. You can visit samspursuit.com to find the links to our 911 Nonsense merch page and our recently released Noon gear page. Every contribution, no matter the size, goes a long way in helping us continue to better the podcast. We know that not everyone is comfortable being on the podcast, but we still want to hear your stories and experiences. If you have a compelling story and would like to share it to be read by me in a future episode, please reach out to us via email at 911nonsense@gmail.com or through our website's contact section. If you choose to be anonymous, we'll make sure to respect your privacy while sharing your story in a way that resonates with our audience. Thank you again for tuning in. We truly appreciate your support and look forward to bringing you more engaging content in the future. See you next week.